Look at this side-by-side comparison. On the left, an adult heart pumps blood into expanded, active lungs to grab oxygen. On the right, the fetal heart operates entirely differently, relying completely on a glowing umbilical cord connected to the placenta for oxygen. In utero, those fetal lungs are completely submerged and filled with amniotic fluid. Because they are packed with liquid rather than air, the blood vessels inside them are squeezed tight, making them completely useless for gas exchange. Because the lungs are offline, the fetal circulatory system has one critical job: take that highly oxygenated blood from the placenta and route it directly to the developing brain and heart as fast as possible. To achieve this, the fetal body acts like an engineer, constructing a specialized, fluid-filled bypass system built entirely on the physics of pressure and resistance. This diagram shows the fetal circulation path. The umbilical vein carries oxygen-rich blood. Its first obstacle is the fetal liver. To avoid this, the ductus venosus acts as a shortcut, routing the oxygenated blood safely past the liver straight into the inferior vena cava. This diagram shows the fluid-filled lungs creating a high-pressure blockade. Blood avoids this through detour 2, the foramen ovale, a trapdoor sending oxygenated blood to the left side. Any leftover blood meets detour 3, the ductus arteriosus, which shunts it into the descending aorta. The ductus venosus, foramen ovale, and ductus arteriosus operate together as an elegant pressure relief system. They are specifically engineered to bypass the high-resistance, fluid-filled lungs. That pressure system shifts at birth. During the first breath, incoming air rushes into the alveoli, physically displacing amniotic fluid. As fluid drains, the squeeze on pulmonary vessels is released, resistance drops, and blood rushes into the newly opened lungs to get oxygenated. The left side of the heart is now the high-pressure zone. This dramatic shift in pressure slams the foramen ovale trapdoor shut and triggers the closure of the other two detours. The physical intake of air is the exact mechanical switch that converts a parallel fetal circulation system into a standard adult circulation system. Let's look at what happens when this physiological switch fails. If a baby is born apneic, meaning they are not breathing, those alveoli remain locked with fluid. As a result, the pulmonary vascular resistance stays sky-high. The detours remain open, but the umbilical cord has been clamped. The oxygen supply is cut off, causing the blood circulating through those open shunts to quickly turn deoxygenated, leading to profound hypoxia and a rapidly plummeting heart rate. Think about how you would intervene here. If you are trained in adult medicine, your very first instinct might be to start chest compressions or push epinephrine. But remember the physics of the fetal heart. To fix the heart rate, you have to drop the resistance in the lungs. The single most important intervention is positive pressure ventilation. You have to mechanically force air into the lungs to push that fluid out. Neonatal resuscitation is essentially a plumbing problem. You must fix the lungs to fix the heart. This is why the first 60 seconds of the neonatal resuscitation program algorithm, the golden minute, is entirely focused on respiratory mechanics. It starts with a rapid system check. Is the baby term? Do they have good muscle tone? Are they breathing or crying? If they are not breathing, the immediate steps are drying and stimulating the baby. Vigorous drying and back rubbing serve a precise mechanical purpose. They directly trigger the physical crying reflex to kickstart that critical air intake. Next, you clear the airway by suctioning the mouth, then the nose. This ensures there is no physical blockage when the infant takes that crucial first gasp. If the baby remains apneic and the heart rate drops, you immediately apply the bag mask. By administering positive pressure ventilation, you step in to mechanically force the physiological switch to flip. Understanding the fluid dynamics of the fetal bypass system means you don't have to rely on rote memorization of an algorithm. You know exactly why the baby is failing